We'll begin our look at our first system now, and so we'll start to look at the integumentary system. And so the integumentary system is our largest organ and our largest organ system that we have. It covers essentially the entire outside of the body, both including the hair, the nails, and all of the sweat glands that are associated with the skin itself, all doing its job to essentially protect everything that we have within the body itself. And so one of its primary functions of the skin is protection, essentially keep everything that is outside the body out and everything that is inside the body in. And so any kind of foreign invaders that are trying to penetrate through the skin, we're trying to protect it from. Sunlight that's trying to get in from the outside and trying to enter into the body itself as sun rays, keeping that from getting deeper into the body itself as well. And so all of these functions are happening in terms of the protection of the body itself. But at the same time, it's helping essentially the inside of the body to prevent water loss. We've got essentially on the outside of the body, in the skin, we have dead cells. And so those dead cells are protective. They're not going to lose their moisture to the outside world. We've got a large amount of blood vessels. And with those blood vessels, along with the sweat glands, we have the ability to control temperature. If one of those invaders are starting to get into the body, and so they're starting to come in here and make their way in through the skin, we can mount an immune response to it, so we can start to destroy it before it gets into the body and starts to cause us any further harm. We have all kinds of sensory receptors, the ability to determine if something is on the skin, if something is touching us, if something's trying to crawl on us, things like that. It's getting to be mosquito season, and just simply a little fly that is trying to land on the skin there, we're going to be able to detect that through our sensory receptors. And so we can feel that even just touching the hair follicles themselves. In addition, we have two metabolic functions that the skin works on as well. We have excretion, and then we have vitamin D formation. And so we'll talk about those as we go along. So the integumentary system itself is allowing us to put multiple tissues together. And so we have epithelium, we have connective tissue, we have nervous tissue in the skin itself. We've got adipose in terms of more connective tissues. All kinds of different tissues are coming together to make this first organ system that we're talking about today. And so that provides for the ability of our system here to be able to function at its optimum as far as the protection processes themselves go. And so even things like smooth muscle we find on the hair follicles. And so this is what allows us to have things like goosebumps. And so as it changes the position of the hair, we end up having goosebumps there. We've got all kinds of nervous tissue as far as the receptors go. We can detect everything from light touch, deep touch, pain, temperature, vibrations. All of that is able to be done within the skin itself as well. When we look at the skin, we see that the skin itself has multiple layers to it. And so even within a single layer, there's even additional layers. But the three major layers that we have are the epidermis, the dermis, and our subcutaneous or hypodermis. And so different components lie within each one. Epidermis comes in two different varieties, either thick skin or thin skin, and we'll get into that. Epidermis also has layers within it, and so we have 4 or 5 layers of different types of epithelial layers that we can see within that epidermis as well. The dermis has 2 different layers also, and those 2 different layers are the papillary layer and the reticular layer. And then the subcutaneous layer down here is largely made up of adipose tissue, along with some other connective tissues as well. And that layer is the deepest of all 3. So the epidermis has kind of 3 distinct types of layers within it. And so we can see 5 layers depending upon the type of skin that we have. And so what we have here is thick skin. And so thick skin has this extra stratum lucidum. And so only thick skin has that stratum lucidum. Thin skin does not. So in thick skin we have 5 layers. In thin skin we have 4 layers for those different components there. And each layer has kind of a little bit of something different going on as far as the structures and the processes that are happening within. And so we can see that within those different layers themselves. And so we have our stratum basal, stratum spinosum, stratum granulosum, stratum lucidum, and then stratum corneum, going from the deepest all the way out to the most superficial layers that we have there within that. And we'll get into the processes of what's happening in each one of those as well. In order to function, we have some different kinds of cells. The majority of the cells that we have are what we call keratinocytes. And so these are the cells that are making their way up through the tissue. And so they're making their way up all the way from the stratum basal all the way out to the stratum corneum. That's there. We also then have some melanocytes. Melanocytes create the pigmentation that's within the skin. We have our Merkel cells, and then we have Langerhans cells. And so Merkel cells are one of our first cells to give us sensation. And Langerhans cells are basically wandering around phagocytes. They're looking for anything that has kind of made its way through the outer layers of the epidermis and is trying to migrate in. And the stratum corneum here especially, and in thick skin, the stratum lucidum, is all of our dead layers of skin. And so these are all of our kind of expendable layers. Those ones we can slough off, those ones we can lose without really losing any kind of living tissue. So thick skin, like we see here again, is the only part of the skin that has stratum lucidum. And so we find this in the palms of the hands and the soles of the feet. And so essentially the hands and the feet are where we will find these. Think about the stratum lucidum as being areas where we can get calluses. And so those areas of the body where we can develop a callus is where we have thick skin. When we do have thick skin, we don't have hair follicles, and so we don't also have sebaceous glands. And so those two are going to be missing from all thick skin. Thin skin is going to delete this stratum lucidum, and we're then going to start to have, once again, hair follicles. We're going to see sebaceous glands. And thin skin we find basically all over the rest of the body. And so basically anywhere that we don't have thick skin, we have thin skin. Because the skin makes its way up from stratum basal all the way up to stratum corneum, this process normally takes roughly 30 days. And so the normal kind of growth of the skin is 30 days. So essentially, as we go through the class, by the end of 4 weeks, the skin that's developing now is at the basal layer is going to make its way all the way out to the surface, assuming that we don't have any kind of excess abrasion or anything like that. But if a person has psoriasis, their skin formation moves much more quickly. And so going from that stratum basal all the way up to the stratum corneum, it can take anywhere between 7 and 10 days. And so what ends up happening is they get this dry, flaky scales that really kind of come off. It comes off in little patches, essentially. And so with that, depending upon the type of psoriasis that they have, you'll see kinds of the inflammation and the redness that's underneath it on things of the body itself. It's common in places like the elbow, the knees, the scalp. Sometimes when people have psoriasis, it may look like they have dandruff because it's in the scalp itself. The pigmentation of the skin is all dependent primarily upon melanin. And so melanin is our primary pigmentation. It comes in kind of different shades of pigmentation that is there, and that's dependent upon the genetic makeup of the individual. But our melanocytes that actually produce the pigmentation is the same in terms of its general distribution from one person to the next. And so essentially everybody has the same number of melanocytes. It's just dependent upon the type of melanin that they produce and the quantity that their melanocytes produce at a basal rate. So kind of the normal, it's the dead of winter and you haven't seen sun in a long time. The amount of pigmentation that your skin has at that point is kind of that basal rate that's there. And that's where the genetics come into play to set that rate of pigmentation, as well as the kind of coloration of the pigmentation itself as well. In addition, we can have things like hemoglobin pigment the skin as well. And then we can also have things like keratin. And so hemoglobin is one that's going to be found in things like blood. And so when we get a bruise, things like that, it pigments the skin deep to it because it has leaked out into the tissues itself. Keratin we primarily get from our diet. And if we have things that are in having an excess of keratin within the diet itself, primarily things that are orange, so carrots, sweet potatoes, things of that nature, all have keratin as a pigmentation. And if you're eating a whole bunch, that can lead to the pigment coming out into the skin. And so the person starts to turn orange in a sense. This is common in infants when they start to eat solid foods, because oftentimes their first solid foods are things like carrots and squash and sweet potatoes, things like that, because they're all relatively sweet to the taste, and babies generally like them. And so they may get fed them a lot because that's what they prefer, and then all of a sudden, new mom has an orange baby, and they go rushing back to the doctor to find out what's wrong with their baby, and it's just simply that they're eating too much orange food. Within the layers of the epidermis, we have the ability to form little ridges. And so these little epidermal ridges that are there are formed in specific areas of the skin where we start to see these little folds. And where we see them, this begins way back in the fetal development, and this gives us our fingerprints. This gives us our handprint, our footprint, all of that wrinkling of the tissue that occurs within the hands and the feet itself on there. Deep to the epidermis, we then have the dermis. And so the dermis is our thickest layer of the three in general, kind of in terms of the tissues that are there. And so we have two separate layers within. We have the papillary layer, and then we have the reticular layer. And so the papillary layer is the portion that is right next to the epidermis, and then the reticular layer being the deeper layer. Slightly different connective tissues within them. The papillary layer has areolar connective tissue, a large amount, so it's going to have that resiliency for stretch from the collagen fibers, but then it's also going to be able to stretch some with the elastic fibers. The reticular connective tissue is much more resistant to stretch and being pulled on and things like that because it has dense irregular connective tissue within it. Lots of blood vessels. Almost all of our glands are in here in terms of our sweat glands. Hair follicles begin to grow from this point. We're going to have our hair root plexus, the individual nerves that surround them on the hair bulbs themselves. We're going to have different types of sensory receptors in this area as well. The skin is relatively highly innervated, and the innervation that it has is variable in different areas of the body. And so different parts of the body will have different densities of all of these receptors. And so we may have more or less of the receptors in specific areas of the skin. And when we have a high density, we're going to have very, very precise touch abilities. We're going to be able to discriminate very well between two different objects or between two different points. versus if they're spread all out, we have relatively little discrimination with them. And so this is kind of the difference between, say, your fingertips, where we have very densely packed together receptors, and, say, your back. And so we're not really going around feeling things with our back, we're going around feeling things with our fingers. And so that difference there comes into how well do we have to be able to discriminate the things that we're actually touching at that time. Blood supply coming in provides for into the dermis here, comes up from the hypodermis, makes its way into the dermis, and goes all the way up to the area just below the epidermis. And so we're going to have little bundles of capillaries here just deep to the skin. And this is what's going to allow us to, in a sense, change the amount of blood flow going to the skin and thereby either conserve or get rid of excess heat that's there. The deepest layer is our hypodermis, and this is going to be a mixture of areolar and adipose. And so depending upon how much adipose is there, in some areas of the body there is more, some areas of the body there is less. Think of like your hands, your fingers. There's going to be a lot less of that adipose layer that's there, or in and around joints themselves generally. And so your elbows, your finger joints, your ankles, your knees, and so on, you're going to be able to touch relatively easily kind of the bones that are underneath. The ankle is probably the easiest example of that. You have your malleoli, your ankle bones that are on either side, and there's basically very little subcutaneous layer there. There's not a whole lot there, which is why every time you bang your ankle, it hurts. There's no padding there. There's no hypodermic layer there to provide for protection. One of our accessory structures that we have for the skin are the nails. And the nails really are just an extension of the skin itself. And the reason why they are a lot harder than our skin is that the nails have a modified keratinization to them. And so the substance that allows our keratinocytes to get their name is that they produce a substance called keratin. And the keratin that we find in nails is harder than that which we find in the rest of the skin, and it's also very densely packed together. And so it forms the nail itself that we see. The component in terms of some things that we can see on the nails themselves, and so we have things like the lunula, and so that's that moon-shaped white region of the skin just off of the skin fold, and so that lies just underneath there. And so we can see that structure there. In that area, we have a little bit slightly thicker stratum basal, and so that's what causes that little component to be there. Underneath so in through here, we have the so-called cuticle in a sense. And so the true name of the cuticle is the epineconium. And so that's the one on the top. But there's also one underneath called the hyponeconium that is right near the free edge of the nail. And so those both, whether it is the epineconium or the hyponeconium, they're basically sealing the skin to the nail itself. And so they're going to allow for that to seal down and create a seal so that nothing is able to really get in underneath the nail and cause any kind of infection or anything underneath there. We don't want that. The nails themselves are great for protecting what we call the distal tufts. And so the last portion of the bones for our fingers, we have the last phalanx, the distal phalanx that's there. And just imagine if you didn't have your fingernails, it would not really be very stable out here in the finger itself when we went to go grab something. And so that kind of stabilizes and prevents the tip of the finger from distorting when we use our fingers or toes. For our hair, we have kind of a process here in terms of growth, where we're going to start way down deep in the skin, down in here, and the hair is going to grow up from that point. And then as it extends out, comes out, becomes the shaft of the hair, and eventually exits through the epidermis and makes its way out to the surface itself. It has associated with it sebaceous glands, and so they secrete out onto the hair shaft itself. That's what's going to keep the hair shaft pliable. It's going to keep the hair shaft nice and flexible, because similar to the skin, the hair itself is all dead cells. And so it has all of these dead cells on it, and they're just built into a filament. Once again, the keratin that is there is a stronger keratin than that of the rest of the skin. So that's what gives the hair its strength to it. And essentially, we have hair all over the body. Thick skin does not. So the palms of the feet, or the palms of the hands, the soles of the feet, both do not have hair follicles on them. Parts of the external genitalia, the lips, the nipples, all of those do not have any kind of hair follicles on them. Functionally, the hair does a lot for us. One of the big things is sensory reception. And so it allows for us to detect when something is touching us. That's there. We have protection from things like the sun. And so the hair on the top of our head works almost like a hat to block that sun from beating down on our head. And also in the winter, from heat retention. Kind of works like a hat once again to keep the heat from escaping out. Where we have thick and thin skin, we also have different kinds of hair as well. And so we have 3 different types of hair. We have the first hair, in a sense, that we get is what we call lanugo. And so lanugo is the hair that we're born with. And this is what really kind of covers all of our skin. We have terminal hair when we're born as well, over places like our scalp and our eyelashes and our eyebrows. But that's the only place where we have terminal hair as a newborn. All the rest of it is this lanugo, which is a very fine, unpigmented hair that's there. Kind of, if a baby is born a little bit premature, oftentimes the lanugo will be very, very prominent. That lanugo is oftentimes caked with what's called vernix caseoso, and this vernix that's on the skin and the hair itself is protective while the fetus is inside the uterus, inside the placental sac itself. Vellus hair is what will come next on places like our arms and our legs and things like that. Again, this is typically lightly pigmented, and this stays until puberty. In males, all of the vellus hair on the body will convert over into terminal hair. And in females, a lot of times, much of the hair on the body will still remain as vellus hair as well. And so that will change depending upon whether you're male or female. Hair pigmentation is similar to that of the skin. We have melanocytes as well. And so depending upon how much melanin is being produced dictates the pigmentation of the hair. Dark black hair is going to be highly pigmented. Blonde hair is going to be relatively little pigmentation. Because the skin and the hair itself is all dead, it can also be bleached by things like the sun. And so just sun exposure will cause slight changes to the hair itself as well. That's there. Not all hair, even within an individual person, is the same pigmentation either. There are variations that are there that'll go along with it. And as we age and as we go through different stages in our life, the hair itself will be affected by the hormones that we have or lack thereof, depending upon age. The glands that we have within the skin are designed for protection as well. And so we have different types of sweat glands, and then in terms of the body, and we also have sebaceous glands. And so the sweat glands come in two varieties, our merocrine glands that we talked about before and apocrine glands. And so the merocrine glands are the ones that are producing a very watery type of a secretion. These can sometimes be referred to as like our nervous types of glands. And so when we get nervous, our feet, our hands start to sweat on those. Apocrine glands are ones that we find oftentimes in the axillary region and the groin. These ones become active during puberty or become active at puberty and then continue to work on from there as well. These ones are going to produce more proteins and more lipids in the secretions. And so this is what ends up feeding the bacteria on our skin. And this is what causes some body odor with those as well. Sebaceous glands we talked about a little bit with the hair follicles. And so with hair, we get the sebaceous glands associated with them. They act as a lubricant for not only the hair follicles themselves and the hair shafts, but also for the skin that's there. If they become clogged, they're going to become acne. We can modify those apocrine types of glands and make them into ceruminous glands. And so this is what's going to produce cerumen in our external auditory canals. And so this is what produces our earwax that we commonly call it. We can modify those glands again and we get mammary glands. And so mammary glands are just glands that are secreting a combination of water and lipids and proteins and carbohydrates that is there. And so this is how we get milk from those glands. As our skin ages, it's susceptible over time to the environmental factors that we have. And so things that we find out in the air, in the water, things that we put on the skin, things that are affecting it as far as environmental things like smoking and vaping and sun exposure all tends to change the skin itself. And so it becomes less resilient. It doesn't bounce back as well. We start to see wrinkles forming, things like that. The glands produce less over time, so the skin becomes drier over time also. The cells turnover rate may slow down, so we may see alterations in skin pigmentation as well as skin thickness in terms of the protection that it has there as well. As we get decreased amounts of sweat production, that makes oftentimes the elderly more heat intolerant, so they don't have the ability to sweat as well, so they're not going to do well with higher temperatures. But at the same time, they also lose a part of their fat distribution, so the subcutaneous fat starts to decrease a little bit, and so that leads them to be also cold intolerant as well. So they start to lose some of that temperature regulation processes that's there from the skin also. In terms of our skin, one of the big things that we do produce with skin is vitamin D. And so vitamin D production does go down with age as well. And so that's one of the changes that occurs there also. Those Langerhans cells that we had decrease in terms of their amounts also. And those cells are normally our first immune response. And that leads to the potential for accumulation of more damage and the potential for skin cancers. So this picture here shows a image of unilateral dermatoheliosis. Essentially, we have wrinkling of the skin, more so on the left side here than on the right side. If you were to kind of draw a line down the center of the face and kind of cover up one side versus the other, you really see kind of two different ages of this person. And so what this happened was for him was that he was a truck driver, and essentially the left side of his face was out in the sun more often over his career. And so that side of the face wrinkled and became much more aged in a sense because of the damage of those UV rays on there. It just goes to show how much damage sun exposure does over time. With sun exposure, we have the potential for skin cancer as well. And so with skin cancers, we have three major types: basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. And so with each one, we have the potential for cumulative damage that may have actually started way back when we were a child. So of the three, basal cell carcinoma is, in a sense, the one that you would want to have because it is the most treatable and it is the most preventable to come back. Because a surgical incision, essentially removing the lesion, will cause it to be gone. And so basically 99% cure rate just by simply removing it. Whereas squamous cell carcinoma, we have the potential for it to grow and become malignant as well, where it's going to start to spread on there. But it does typically have a good prognosis, especially if found early. This is one that can be treated. Again, excision, remove it, possibly some treatment afterwards. Radiation is sometimes used. Also chemotherapy. With skin cancer, chemotherapy tends to be things like just simply a lotion. And then we have melanoma. And so malignant melanoma or melanoma is the most aggressive of the three. This is the one that you definitely do not want to have because even though it is aggressive in terms of its growth, it can relatively quickly spread. And so the other thing is that oftentimes it doesn't really look like a whole lot. And so there's not a whole lot of difference between this one and kind of the other mole that is right next to it. But the telltale sign that is there is that it has two different colors inside. And so this area here is all lighter than that other area. And so this area here has a slightly darker pigmentation. And so the pigmentation is not uniform. And so there's some asymmetry in terms of the coloration that's there, causing some concern as far as the side. And so we use the ABCs as far as guiding whether it's potentially melanoma. Is it asymmetric? Are the borders irregular? Does it have kind of indentations or looks like something was taken out of it? Is the color the same within the mole, as well as does that one particular mole kind of match the pigmentation of all the rest? In other words, is it uniform throughout the entire body? And then size, has it grown bigger than the end of an eraser? And here we have some examples of just simply between the benign type and the malignant type. And for a lot of them, generally to the average person, you're not going to see a whole lot of difference between them. They're just going to look like a mole for that person on those. And so prevention is the key. Preventing it in the first place from overexposure to sun, getting those sunburns, things like that. And then prevention as far as keeping an eye on all moles that may be found on the skin.